Good afternoon. Thank you so much for having me. And I'm going to be discussing our work on diagnostic errors in healthcare. Just a quick show of hands. Anybody from the audience has had a family member or a friend who has been misdiagnosed in the last 5 years? Just raise your hands. About a third of the people have raised hands just in this room alone. This is an important problem. I'm going to talk to you about a story first. This is Rory Staunton. He was a 12-year-old boy who presented to a pediatrician in New York. Was having symptoms of gastroenteritis, nausea, belly pain. He was throwing up. Was sent to the emergency room because he looked sick. In the emergency room, he was given some fluids and sent home after some blood tests. Next day, he got sicker and came back to the same emergency room. He was told he's really, really sick and he's going to be admitted to the ICU. 3 days later, Rory Staunton died from streptococcal sepsis. What was found on the assessment of this case was that when he presented for the first time, his diagnosis of sepsis was missed. He got fluids in the emergency room, but his blood pressure and his heart rate never got better. He also had a rash, which was a black mottling of the skin, but that was not really picked up by the emergency room. So there was a physical exam finding, but nobody sort of saw that. And then most importantly, he had a blood test that was suggestive of a rip-roaring infection, but that blood test was not picked up. It was missed by everybody, and we didn't find out till the next day when he came back to the same emergency room. Unfortunately, stories like this of Rory Staunton are not that uncommon. With AHRQ funding, we actually did the study to try to get an estimate how common are errors in diagnosis in US healthcare, and just make an estimation. Based on our estimations, about 5% of US adults every year will get a misdiagnosis. 5% is 1 in 20, and that amounts to about 12 million US adults that get misdiagnosed every year. Now, not all of these are harmful, not all of these lead to death, I must acknowledge that, but this is a very common problem. Now, there was a National Academy of Medicine report which was co-sponsored by AHRQ, which again made an estimation based on some of the numbers that I'm telling you, that said almost all of us are going to have a missed or a delayed diagnosis at least once in our life. So again, this is the National Academy of Medicine report, Improving Diagnostic Healthcare, came up with good recommendations on what we can do to fix the problem. Now, what have we been doing for the last 15 years in this area? Well, we've been really busy. We've been trying to define the problem of diagnostic errors. We've been trying to measure the problem, figure out why these things happen in healthcare, and then this would lead to actions to reduce the problem. Now, what we're trying to do, it looks sort of simple, but moving up that arrow is not. You need research to stimulate how to move from defining the problem to going up into action, and that's what we've been doing thanks to a lot of AHRQ funding. What has our early research shown? Well, one would imagine it would be rare things that would get missed, right? So the uncommon diagnoses and things like that. No, it's actually the common diagnoses that get missed. So it's things like cancers, infections, and cardiovascular conditions, heart attacks, strokes. All of these are the common conditions that get missed. Now, many of these are related to things not being picked up in the basic clinical skills, such as history and exam, listening to patients. All that time is getting really compressed and pressured. And so we're overlooking some of these red flag findings, and the Rory Staunton story really illustrates that. Typical emergency room, there's lots of chaos and interruptions, and you've got lots of sort of alarms going off, and you miss findings. We're also overlooking information which is already present in the electronic health record. So we've seen cases where supposedly somebody's chest x-ray was done 6 months ago, maybe a year ago. It's abnormal and nobody's picked it up so far. And so things are getting buried in these electronic medical records because we haven't been able to sort of find the finding that was abnormal from 6 months ago or from a year ago. And a lot of these things we're finding is the way the health system is structured and the way the healthcare delivery system works, it influences the way clinicians think. So if I have 10 minutes to see a patient in my primary care clinic, and if I have an electronic health record that is quite burdensome, I'm doing data entry, with all the documentation requirements, I'm not listening to the patient a lot, and I might miss something because I'm then getting interrupted from, something else. So it is really a time-pressured environment. So the health system delivery, the way we are structured, influences the way we think. That's a really important finding that we're coming up with. We're trying to create signals to bolster error measurement. So what does that mean? Well, measurement is the first step to improvement. If you can't measure it, how are you going to manage it? So you really need to try to figure out how do we learn about these errors so we can identify the problem and fix them. So we've asked clinicians, but doctors really don't like reporting errors. So it's really hard to get reports from doctors themselves about the errors they made. We have been able to do that, but it's hard. We can ask patients, and guess what? When we talk to patients who are misdiagnosed, one of the things they tell us is doctors didn't listen to them. That was the #1 reason why they got misdiagnosed. But what we've been trying to do with AHRQ funding now is trying to review these high-risk cohorts. So let's say patients with cancer, we found about 1/3 of patients with cancer would have some missed opportunity or a delay in their care. That's quite a high number, about 1/3. We've also developed with AHRQ funding what we call e-triggers, electronic triggers, which are essentially queries that can tell somebody to review the medical record to find some problem. Essentially, if you do this in a large, big data warehouse, you're almost like picking out needles from a haystack by making the haystack smaller and using a magnet to pull out those needles. So we really can take this to scale with electronic algorithms. Just example, if you've got a patient who is admitted, healthy patient coming to the hospital, rapidly deteriorates and goes to the ICU unexpectedly, we want to review that record. So that can that query would be applied to thousands and thousands of medical records and will identify just the few that we needed to review. And that really makes the scale of finding these errors really, it takes it to scale. We can also identify patients through these e-triggers, patients who are having delays in their diagnosis. So if you have an abnormal test result, such as a chest x-ray, or it's a lab test, it's abnormal, it hasn't been picked up and followed up, we can develop these queries now to identify from electronic health records what to do next. Now, this research is not sitting on the shelf. It is actually being influenced a lot of work. So with AHRQ funding, again, we are trying to create these learning health systems, which are partnerships between the health systems as well as engineers and other types of researchers who can influence the way we structure care and deliver it better. And we call these learning labs. So essentially, these learning labs are ways to find and fix things, and that's what we're doing. We're also trying to create best practices that health systems can use to implement in their in their own setting. So how do you close the loop on an abnormal test results so patients don't get fall through the cracks of the healthcare system? We're trying to come up with strategies to engage patients. So for instance, patients should know about their test results. If you have not heard from your doctor, no news is not good news. So you got to go back and make sure that your test result is not abnormal. And then we're trying to use better use of electronic health records. So we're trying to make patient portals better, we're trying to make electronic health records better. All of this has been stimulated from initial AHRQ funding, as well as other funders that I'm going to acknowledge at the end. So looking towards the future, this is my wish list initiatives for the next 5 years for AHRQ. They have a lot of work ahead. I would really encourage AHRQ, along with the funding that they would get, to stimulate multidisciplinary research. Remember, the key is multidisciplinary. You've got to have clinicians working with other folks, psychologists, behavioral scientists, informaticians, engineers, to make the healthcare system better, and I'll give you examples of why. We need to measure and reduce this at a national scale. This is a national problem. It needs to be tackled on a national scale. And only an agency like AHRQ can do that. We then need to take all this research and implement that into real-world practice and influence policy. Essentially, we don't want this research to be sitting on the shelf. So it's really important to translate this research into evidence. And there's a paper outside in a handout, which I would really encourage you to read. What we said was we did an assessment of the patient safety, what's the state of patient safety right now in the United States, and what have we learned in the last 20 years since the landmark report came out. Essentially, I don't know whether that's good news or bad news, we're still in the sort of the bronze age of patient safety. What we really, really want to do is to go to the golden era of patient safety over the next 5, 10, 15 years. And I strongly believe that an agency like AHRQ can help us do that. I want to thank my funders. This takes a village, the type of research I'm describing. So all the funders are listed on this slide. And I want to also, this is a team effort. So I want to acknowledge my team, a multidisciplinary team based out of Houston and Baylor College of Medicine at the Houston VA. So thank you very much for listening.